Many patients who have prostate cancer have cancer cells beyond the prostate which have not spread to the bones or to the lymph glands. These patients are called locally advanced prostate cancers. They're a difficult management group because it's hard to cure them with one treatment alone. There are two very clear pathways that we can manage patients with locally advanced prostate cancer. The first way is to surgically remove the cancer, but with the knowledge that it may be necessary to give follow-up radiotherapy and possibly even hormone therapy after that treatment. The other way is by giving very high doses of radiotherapy, and this can be either given with IMRT radiotherapy or with high-dose rate brachytherapy in combination with external beam and in combination with hormone therapy as well. So there's very clearly two pathways to go. So how do we choose between these two pathways in an individual patient? Well, firstly, as with all situations, we consider all the factors. The critical factors in making the decision here is the patient's age. The younger they are, the more likely we are to consider surgery. Secondly, whether the surgeon feels he can eradicate the vast majority or all of the tumour with surgery alone. And if he can, then surgery may be the best first option. Thirdly, the patient priorities, as surgery followed by radiotherapy often eliminates all erectile functioning, whilst radiotherapy with hormone therapy may not. And finally, to do with urinary symptoms. With severe urinary symptoms, it's better to have surgery first, whereas with minimal urinary symptoms, this allows us to consider radiotherapy first. So that's how we choose between the two different big groups of treatment options for people with locally advanced prostate cancer. In the end, it requires the experience of the individual urologist, and with these cases, it requires a lot of experience to tailor the therapy and get the best outcome. I've been very interested in this area for a long time, and we actually looked at the outcomes comparing the radiotherapy group and the surgical group, and we've learnt a lot of lessons as to how we can tailor and personalise the treatment in this situation. So it's a challenging area. We know that it requires more than one treatment in many, many patients, and the side effects are more, but we're still very, very encouraged by the cure rate of these patients, and even if we don't cure them, by the control over many decades.